Senator Johnson.
Thank you, Mr. Chairman. First of all, thank you for this hearing. This is another one that I think is highlighting the fact that we have a horribly broken medical financing system. And I would argue that Medicare has not helped that, and I think the testimony today pretty well proves that, because we're talking about the payment schedules, how it's distorted medicine. I don't even want to call it a market, because I don't think we have a market in medicine anymore. And, you know, I listened to Senator Stabenow say we've been talking about this for a long time. Dr. Turner talked about innovation. I think somebody else talked about being flexible. Well, government doesn't really drive innovation very well. Government's not particularly flexible, and that's the problem we're all dealing with here. So I really want to focus on, I'm sure you probably didn't want to be practicing for 80 years, but I'll take 40. I wish I could talk to a physician who was practicing 80 years ago. But what I want to focus on, Dr. Furr, is forget the medical innovations, which have been unbelievable, what we've been able to do in the last number of decades. I mean, what we can do in medicine is truly remarkable. But just the practice of medicine, is it better today or worse? I mean, would you like the medical innovations, but being able to practice in the 1980 model? Do you know what I'm trying to get at here?
Yeah, it is better. I mean, years ago we had people die of just benign infections. We didn't have penicillin.
But again, set aside the medical advances, yeah. Just about the practice. I mean, your primary care physician, we're not able to track them very well. I mean, it seems like solution here is a more primary care physician model, which we had more closer in the 80s, probably more so in the 50s and 60s.
Yeah, I think, you know, we've got better, like you say, advances and all, but as far as the stress of practicing, it's much more difficult now than it's ever been. Physicians used to work hard, but they spent their time taking care of patients. They don't feel like they're spending time taking care of patients now. They're doing prior authorizations and other things to get those innovations there, but there's not as much enjoyment.
And again, they're doing those authorizations because you have to do it for Medicare, Medicaid, you have to do it for insurance. You have to do it for a third-party payer system, correct?
And not for the patient.
Didn't have to do that when you were actually billing the patient direct, when you had consumerism in healthcare, when you had patients making the decision, do I want to go to 10 different specialists, or do I really want to rely on a primary care physician, kind of let him work with me to make those decisions?
That's correct.
Again, the point I'm making is, I've said this, whether we're talking about our overly complex tax system or our completely broken healthcare financing system, we're talking in this committee about putting a Band-Aid on a dying patient. And I'm trying to figure out how do we revive the patient? How do we bring back consumerism? I often say there are two areas of our economy that we're very just habitually dissatisfied with: education and healthcare. What they have in common is we've largely driven the benefits of free market competition out of both areas, and in particular in medicine. How do we get it back? Again, we're not going to do it through changing a fee schedule. And Ms. Matthews, I know you've got you've got your own little solution here. It's not a solution. It's really not fixing things. It's maybe improving things marginally. But we are paying what? Double what World Health Care costs are, and we're getting, in many cases, worse outcomes. I mean, this isn't working. We need a paradigm shift here. We need to think outside the box. Again, I just don't think putting a Band-Aid on the Medicare payment system is going to do it. I mean, anybody have any ideas? You just want to comment on that? Dr. Turner, you look like you want to say something.
Well, thank you for that question and for that comment, Senator. I do think that the opportunity for those closest, the subject matter experts, to propose innovative ways to provide better care and bend the cost curve, as was the plan, we think, under MIPS, is probably a good idea. Bringing some of those good ideas that came forward through the PTAC and allowing them to actually be tested and implemented, I think will get at part of what you're describing. One size does not fit all. Making sure that we are centering the patient and that we have the subject matter experts propose what could really be the innovation that could help to change the conversation, that is part of the solution. And so thinking about some of those great ideas, we had one, other specialties brought forth smart, innovative, thoughtful, solution-oriented ideas to the PTAC, and then they weren't able to really be tested and then ultimately implemented. So that would be one possible of the many solutions that might address what you're describing. But agree with you entirely that when we talk about access and in the rural community, and we have surgeons that are out there trying to keep their practice doors open who want to provide care, but the administrative burden is so onerous that in those critical access hospitals where they're the only game in town, so to speak, we want them to be able to provide the care that they want, and the administrative burden is overwhelming them.
And it's the administrative burden that's just a self-inflicted wound, and that's what we need to stop doing. I'd love to talk about the prospects of using AI, more expert systems in medicine. I've seen that debate over the decades, but don't have time for that as well. But thank you, Mr. Chairman.